Minutes, I would like to give you a brief overview about diagnostic and therapeutic possibilities in primary sclerosing cholangitis. What is PSC? PSC is a chronic cholestatic syndrome of really not fully known etiopathogenesis, and many factors are involved in. It's characterized by inflammation and fibrosis of intra or extrahepatic bile ducts. The incidence is quite low, but increasing over the time. And if you want to search for the patients with PSC, you can find them mainly in the United States and North Europe. There is a very clear and tight association with IBD, which is present in up to 80% of the patients with such a specific phenotype. And median survival rate is in between 12 to 17 years, meaning that liver transplantation represents the only effective treatment. And especially in our institute in Prague, the PSC represents the third leading indication for liver transplantation, accounting for about 10% of all patients going for liver transplantations. And lastly, it's very important that PSC is associated with a very significant neoplastic potential. The diagnosis is mainly based on ERCP, but MRCP is recognized and developing as a non-invasive modality, and nowadays it represents a preferred method. Both methods are showing diffuse multifocal strictures and irregularities with normal segments in between, so-called therapeutic pattern. Histopathology represents just an adjunctive method. That means just in the case if we cannot clearly evaluate the diagnosis of PSC on the X-ray pictures or on MRCP, we will perform the liver biopsy to confirm the so-called small bile duct PSC. On the histopathology, onion skinning fibrosis is nicely seen around the bile duct in the case of the PSC. To obtain the proper X-ray picture, we can very often use balloon occlusion cholangiogram. As you can see here, if we will not perform it, we will not obtain such a clear picture as you can see on the right-hand side. So the proper diagnosis is done by this method very often. Even the position of the patient is very essential, especially if you want to follow the patient a long-term period to compare the changes during the time. And as you can see, there are differences on the position of the patient. So supine position is essential according to my opinion. In the differential diagnosis, it's covered the potentially treatable disease like IgG4, sclerosing cholangitis, and biliary sarcoidosis. Advanced portal hypertension is associated with the same X-ray pictures as seen in a PSC. And of course, the major differential diagnosis is a cholangiocellular carcinoma. The IgG4 sclerosing cholangitis was firstly described in 1995 in a patient with pancreatitis, and since that time it's more and more recognized in the clinical practice. The typical patient is the older man or the male with obstructive jaundice, with raised serum IgG4 level, and signs of the pancreatic involvement. The inflammatory bowel disease is less frequent, and this disease, and this is very important, is very responsible to the course of corticosteroids and immunosuppressants as well. As I told you from before, the cholangiocellular carcinoma represents a nightmare in our clinical practice, as almost 10 to 15% of those very young male mainly will die because of cholangiocellular carcinoma, despite if you perform the screening or not. Duration of PSC is not associated with increasing risk of cholangiocellular carcinoma, meaning that a lot of cases are discovered and confirmed even in the time when the diagnosis of PSC is established. For tissue or bile tissue acquisition, we can have a brush cytology and intraductal biopsy using very often the spyglass. And advanced techniques are available for our daily practice, like FISH, that means the fluorescent in situ hybridization, but sensitivity is still not so perfect. There are many protein biomarkers in the bile using in the clinical studies, but unfortunately they have not trials yet in our clinical daily practice. So you can see really the pictures of cholangiocellular carcinoma and benign disease or benign dominant structure looks the same. So first of all, we really need to rule out the cholangiocellular carcinoma in case of dominant structure. As I told you before, the PSC is really tightly associated with inflammatory bowel disease, this distinct phenotype of UC, which is characterized mainly by right side predominance of inflammation. And what is most important is that even with the right side predominance of colorectal neoplasia. And as you can see in this picture, the incidence of colorectal neoplasia is at least 5 times higher in those with PSC than is compared with the patient with USC alone. Endoscopic treatment, according to my opinion, represent the most important therapeutic strategy currently available. Our target or our effort is focusing on the recognizing and treatment of dominant structure. And what is dominant structure? Dominant structure is the structure with diameter of less than 1.5 millimeter in the common bile duct and less than 1 millimeter in the hepatic duct. In the long-term follow-up, such a dominant structure will develop in almost 2/3 of the patient. And what is most important is that the survival rate of those with the dominant structure is significantly less than as compared with those without. It's characterized by obstructive symptoms and decompensation of the liver function and high risk of the bacterial cholangitis. Repeated balloon dilation and sometimes accompanied with the short-term stent insertion represent current gold standard for the treatment of the such patient. Ideally, we are using dilation up to 2 centimeters proximal of bifurcation, and preferentially we are using balloon for dilation. Decreasing of alkaline phosphatase of at least 40% represent a marker of success. As you can see in this patient, dominant structure, nicely seen here, was recognized near the cystic duct. The balloon dilator was introduced and inflated up to 6 millimeter, and dominant structures resolved after that. In the case of long stricture, rigid one, so we are using the rigid dilatation using bougies, but the results in this field are less convincing. If we will decide to insert a stent, technically it's really accompanied with a high successful rate. But and short-term stern insertion, as I mentioned from before, is effective for short time period, meaning 1 to 2 weeks. But we should be aware that at least 1, 3, and even more patients will underwent next ERCP as an urgent procedure, meaning due to stent obstructions accompanied with a cholangitis. And stents itself are increasing risk of bacteriobilia and could block the outflow of the bile from the small biliary tree. But honestly, there are a lot of patients, not so lot, but there are few patients when we should insert a stent, even knowing the risk of this procedure. But in these patients, as you can see here, with a long, rigid stenosis, which is refractory to the balloon dilation. This is the very important thing. And we are using with the distinct stents with the side holes or the wind stents for those patients. Our approach is based on quite a long study, which was discovered, it was published before a long time, 2001, when the complications in the stent group were higher, meaning cholangitis and procedure-related complications. So we are now waiting for the result of the newly performed European prospective randomized study comparing a stent insertion, again for the short time period, and balloon dilation for 4 to 6 millimeters for 2 minutes, and hopefully the results of this study will be released soon. Bile in PSC patients, in naive patients, are infected in up to 25% of the patients. So, and even more that, so up to 60% of those who underwent repeated procedure. So ERCP could be associated with a life-threatening cholangitis, and we should be aware that routine antibiotic prophylaxis before ERCP is really essential. Endoscopic therapy has an impact on transplant-free survival. It's improving statistically, it's improving transplant-free survival at 3, 4, and 5 frees as well, as was confirmed by those studies I presented to you. As we heard from the previous speaker, there is no currently established drug treatment for PSC. But in the clinical practice, the UDCA is mainly used. And many studies were concluded to address the issue of UDCA in case of PSC. Mainly, they were showing their effects in the improving of the liver tests and histology score, but not statistical significance of life expectancy was observed. And it was already shown that the study using high dose of orthodeoxycholic acids, meaning up to 30 milligrams per kilo a day, was prematurely closed due to high rate of the severe side effects. A lot of patients were showing the progression for the liver transplantation with the high occurrence of the developing esophageal varices. And additionally, regarding the role of orthodeoxycholic acid as a chemopreventive agent in a colorectal neoplasia, it was shown that a long-term use of high-dose orthodeoxycholic acid associated with an increased risk, even increased risk of colorectal neoplasia than in patients with UC and PSC as compared with placebo. So again, harmful role of high dose of UDCA in the PSC patients. So what's the role of UDCA in terms of chemoprevention of colorectal neoplasia? UDCA itself is associated with a lower risk of advanced colorectal neoplasia, and in the low dose, meaning up to 15 milligrams per kilo a day, was associated with a significant risk of reduction of all colorectal neoplasia. Alkaline phosphatase represent a very important prognostic factor in PSC patient, and it was published last year. It was published last year, showing that if the patient, the survival rate of the patient with alkaline phosphatase of 1 to 3 times more than upper limit of the normal was significantly lower as compared with those with the better chemical or biochemical profile. So what we will do with the patients with PSC? Should we stop the treatment of ursodeoxycholic acid? And this is the study. This is the Polish study. The study was yesterday received the first prize of the Dr. Barres Award. That if we will continue ursodeoxycholic acid, in just 3 months after that, the patient will face the increasing of the liver tests, especially alkaline phosphatase, up to and more than 70%. So if withdrawal is bad, then administration is good. The answer is not so easy. And I think we should use the rule of the personalized medicine. And we need to identify the proper patients, and in those to rule out of cholangiocellular carcinoma and so on. And in those patients, we can start a 6-month trial of ursodeoxycholic acid with low dose, or up to 23 milligrams per kilo a day, for 6 months, and clearly and tightly monitor them. If we will see a 40% reduction from the baseline in ILP or normalization, which I showed you from before is associated with the better survival rate, we can continue on this treatment. If not, we need to evaluate experiment therapy. And it was shown nicely from the previous presentation that one of the very promising and awaiting drug on our market will be ursodeoxycholic acid, meaning that small changes in the molecule are associated with the high changes in the functioning of this molecule. It's more hydrophilic. It's inducing the bicarbonate rich. This umbrella was nicely showing, and even the additional mechanisms of ursodeoxycholic acids include antifibrotic, anti-inflammatory, and anti-proliferative agents. And new kids are on the block as well. And what's already, I think we already heard about them. So antibiotic vedolizumab. There's a study now ongoing, phase 3 on vedolizumab on the treatment of PSC. We heard already about the obeticholic acid, and of course about the ursodeoxycholic acid. So let me conclude. Dear Chairman, ladies and gentlemen, the diagnosis of PSC is based on MRCP mainly now, and of course on ERCP, always in collaboration with colonoscopy. Liver biopsy itself is seldom needed. PSC IBD represent a distinct phenotype of IBD and is associated with a high risk of follicular neoplasia. The most important differential diagnosis currently represent, of course, cholangiocellular carcinoma, but immunoglobulin-associated cholangiopathy as well. Therapy of PSC is currently based mainly on the endoscopic approach. Currently, there is no established medical therapy. Use of ursodeoxycholic acid for PSC and as a chemopreventive agent for colorectal neoplasia should be very carefully indicated and dosed properly, and novel therapies are on the horizon. Thank you very much for your kind attention.